first of all, bon dia. Good morning, everyone. I'm Joan, and I'm going to explain you. First of all, I would like to thank the organizers to give us such a great opportunity to explain how Hospital del Mar faced and is actually facing COVID-19 pandemic. So, just for a start, I don't think that I should need to explain you so much about the situation we are. So could you? Yeah. So COVID-19, SARS-CoV-2 is an RNA virus that is airborne. Its symptoms ranges from completely asymptomatic people to patient death. And its severity correlates with age and comorbidities. It's when a person presents symptoms, one of its characteristics is that it lasts a lot of time presenting them. So, and these long-lasting symptoms, together with its rapid spreading, leads to a huge pressure on the healthcare system. So, with this idea in mind, we decided that maybe we could help people from the clinic, our physicians from the emergency room, and help them with the triage. So, and this is kind of a hot topic with more than 2,000 papers already published. So I'm not explaining here so much new news at this point, but the idea here was to build something that was kind of useful for the people in our hospital, with the hospital cohort. But you know, once down in the rabbit hole, you don't know how deep it goes. So with this idea, we gather a highly motivated group of people from physicians, radiologists, molecular biologists, lawyers, informaticians, and also bioinformaticians, and we built a data set with patients with positive for COVID-19 and also patients with COVID negative. We took from the hospital information system its chest X-rays, and we built a data set. With this one, we train a state-of-the-art deep learning model to predict actually if this chest X-ray was positive or not for COVID-19 infection. And the interesting part here, we managed to deploy it in the hospital information system. And this is not trivial. Marion actually told us that this is quite a bit difficult here in Spain, with so many different information systems in the hospital. And as you can see in the image in the right, the clinician from the emergency room could have a report with the probability of these patients to have COVID-19 and a heat map pointing to the regions where the algorithm was looking at to give such prediction. And this whole process takes less than 10 minutes once the chest X-ray is performed. So another important number here is the period of time we need to do all of this. So less than 2 months from the idea to production. So a lot of work here. I have to thank my whole team for this. But we were very happy at this point. We called the press and tell them, we have a deep learning algorithm going in our hospital. Come here and see how great it is. And things go great for some time. But at some point, some physicians from the emergency room come to us and tell us some interesting stuff. And let me stop here for a minute and explain you how, coronavirus pandemic was in Spain. And here, what I'm showing you is is a plot adapted for our Walling Data webpage, which is a great resource. And it shows you the excess of mortality in Spain compared to previous years, 2015 to 2019. And here, you can see that actually, I'm plotting this rather than the confirmed cases, because in most of the countries there was a problem with the PCR testing at the beginning of the pandemic. And it was kind of difficult to relate actually the situation we face here just with the confirmed cases. So there was a huge peak of COVID-19 patients in the first wave compared to the later ones. And actually, we deployed our model around, end of April. So actually, we were training our deep learning model using data from a completely different scenario than the one we are deploying it. And this points to prevalence. So in the first wave, almost everyone that comes to the hospital was COVID-19 positive. And we trained the algorithm in a way that everything that it says that was rare was COVID. But when prevalence drops, there were in the emergency rooms there start to appear other kind of diseases. And the situation was like clinicians come to us and tell us, okay, I have a patient I'm sure has a heart failure, but look at the COVID prediction. It shows 100% probability of COVID. Imagine our faces at this point. Also, we also already know that some heat maps point to regions outside the lung parenchyma. Although it gives the correct classification, the algorithm was looking at some point outside the lungs. So with this, we decided that, but this was not enough, and we decided to persevere in this, and we built another, and we look for some ways to overcome all of these eventualities. So, the first thing we did was to ask our radiologists again to please segment some chest X-rays, some lungs from the chest X-rays. We built an algorithm with these images to automatically segment lungs. And since we know from the emergency room physicians that there are other diseases that resemble COVID-19 chest X-ray, we decided to include them in the model. So we built another data set with COVID-19, control patients, heart failure patients, and non-COVID pneumonia patients. And not only this, since we know they are similar, we decided to add another source of information for them. And we gathered in a time-wise manner blood tests from the same patients at the same period of time. And we built this data set. And also, we developed a deep learning model that was able to take these two sources of information and combine them in a single prediction for these 4 different categories. And we were very happy with this because when we compare the prediction capacity of this algorithm with the radiologists on the hospital, more or less, the prediction capacity was the same. So and there is more about this, but I don't have time to explain you all of this. We hope all this work will be published in the following weeks. So if you find it interesting, I recommend you to follow our media sources. And just 3 conclusions from the work we've done. First thing, I want to stress this: gather people from different backgrounds is great for a project. And this is something we already know in the deep learning field, where some of the breakthroughs that come in the deep learning world were from people outside it. Also, more concretely from the project, is that when you face complex systems like healthcare, you may need complex solutions, complex models like the one I showed you already. And here I have to admit that NLP is the big accent. Natural language processing is not here in this project, and we are thinking ways in how to integrate this information with the other 2 and give a better prediction. And finally, like a more philosophical one, is that COVID-19 pandemic show us that actually what seems to be true at some point may be completely wrong just some weeks after. And I would like to use this opportunity to tell you that it's important to be critical with ourselves and with information we gather. And when data suggests otherwise, it should not be a problem to change your mind, and I think it's super important. So and with this, I would like to thank the rest of my team, of course, you for listening to me, and the organizers again for the great opportunity.
Thank you. Thank you, Joan. Thank you. You can sit down on perhaps your seat have to go a bit forward, just to let Ian, I will let the floor to you. So Ian Aaviksoo is Vice President of Healthcare for the company Guardtime. Ian is coming from Estonia.
Sit here.
Where you want. You can do at the lectern, up to you.
Yeah.
So, Ian is coming from Estonia. Well, not really last week, but
yes,
yeah, you were
yes.
already there in Costa Brava.
Yeah.
But he's coming from Estonia. Ian had several lives. He's been medical doctor, of course, but as well very involved in the government in Estonia, especially during the presidency in 2017, a presidency of Europe that Estonia led the digital health to move forward. I think it has been one of the greatest presidency we had in this latest year. And now with Guardtime, developing industrial solutions with government as well, with the WHO. But Hein, you will explain us that now.
All right.
Thank you to be there.
Thank you, thank you. I am a very happy person because I had the opportunity to travel here. Yeah. I had, former friends, I could say. We have professionally done many things together. And yes, I did spend for the last 10 years at Costa Brava, and I really love this country. And I love the opportunity to talk to people, to hear what others have been doing. So I really hope that the courage of the organizers of this conference will just inspire all the others. I am currently working at a company which is a deep tech cryptographic engineering company, but I actually come from another area. I've been there for 3 years. And before that, I worked as an undersecretary for e-services and innovation at the Ministry of Healthcare in Estonia. So I was responsible for digital transformation. And I can tell you that I started with, plans like this. And after 6 months, I understood that what you can do in healthcare is probably like this. And after another 6 months, I said, if I can do 10% of what I intended in the beginning, I should be a happy man. Well, I am actually envious to all the healthcare managers these times, because they can do cool stuff. And this is, I hope, has a lasting effect. And I'm going to tell a story of my own and the company. And we started together with the Estonian government and with the World Health Organization approximately a year ago. And that was a continuation of collaboration between the Estonian country and the WHO around, okay, what can we do with the digital experience and technologies from Estonia to help curb the pandemic? And one of the ideas was that, okay, we need better understanding of COVID, individual COVID risks. Actually, there were 2 use cases initially. And you can see that the certificates were kind of keyword, but the original idea was that we should probably have care continuity maintained, because at that time it was already known that some of the vaccinations require 2 dosages. You might get one from one place, then another in another place. It might be a repeated vaccination that you require in the end. You might also need kind of different healthcare providers to help you, and in order to do so, it would make sense that you would have a certificate about your previous health records with you. Obviously, the travel industry, with their tens of billions of dollars of losses, nudged, and right now we have a certificate which basically does just one thing, allows you to travel. Again, I'm happy for that opportunity as well. I'm vaccinated fully, and I can execute this opportunity because of this certificate with much less friction. But actually, what we have been working on is understanding that the effectiveness of vaccination campaigns is more than just giving people that certificate, that piece of, well, not anymore a paper, even though most of the times we still use the paper these days. Hopefully it will be fully digital. But on the back end, there is idea that if the vaccine is combined with health information, then actually the two flows that really meet. So there is a huge logistical exercise from the factories through the supply chain to the clinic. And then also in the clinic, as I explained, and as you know, you need to know, which people are coming to you. Sometimes, there have to be different age groups. You also need to know, do they have contraindications for vaccinations? So that is the clinical workflow. And in order to coordinate the right vaccines at the right place for the right people, actually, there is no system anywhere which is properly functioning, because the sensitive health data is handled separately from that of the supply chain of the vaccines. So what we work with is an idea that if we could combine those two things together, both the clinical workflow but also the workflow of vaccines to distribute and deliver them effectively would become better. So how do we do that? So there is a physical flow, and then we complement that with a digital twin. The digital twin comes with each unique vaccine serial number. These days, the flu vaccines actually have unique number for each shot. For COVID vaccines, currently they come in a carton, so is it 6, 10, sometimes a little bit more. But still, there is a limited amount of vaccines that carry this unique number with them. So now when you go to a hospital or a clinic and get your vaccination, then your ID, as well, information about the disease, and this unique vaccine number and the location will be combined. And this becomes a record about the vaccination. Now, you can generate vaccination certificate out of that. But you can do a few cool things if you add, and those red barrels are the marks of Guardtime technology, which is a blockchain, specific type of blockchain, doesn't contain any data, but it does contain the fact that this vaccine was created, this vaccine reached this clinic, and this clinic used this for that individual. And then, for instance, if you know that this carton had 10 dosages of vaccines, you know that you cannot generate more certificates than 10. If you generate 11th, 12th, or 13th, either somebody is by accident scanning the barcode, or there is some malicious action happening. And also, if you have the geographical location of that hospital, you also know that if this vaccine serial number was used, say, in, Angola, if the same serial number pops up somewhere in Estonia or Croatia, there is something dodgy happening, because this vaccine serial number, this package, cannot be at two locations. So this is, for instance, one thing that UNICEF is currently looking forward, because the counterfeit and diversion of vaccines is a problem. Maybe not that much in the countries like Catalonia, Spain or Estonia, but even here, but more importantly, all the other countries that now WHO and UNICEF want to vaccinate people. But actually you can do more cool stuff, so that you can create unique, what I call statistical artifact. So you take away all the personal information, but you cryptographically link that information, and then you can start giving real-time feedback to the public health authorities. And if there is also agreement with the manufacturers, you can have real-time feedback about where the vaccination is taking place, where the vaccines are needed, and later on also all the effectiveness data, so that you can start building distributed health information systems which are so much needed to support telemedicine, or actually putting together data from various sources. And you can do so because you have proven that it works, and it does deliver value at the individual level, but also at the system level. So that I will finish up with trying to answer the question, will the certificate survive COVID? Well, we don't know in which form. I personally, even though I was heading the project at my company and also in Estonia, I wasn't a big fan of showing a certificate in order to go to a theater, or if my wife is vaccinated and I wasn't because she was a doctor and she can go to enjoy a theater and I couldn't. So I think that the best way to use it is actually build an infrastructure where I personally can carry my health information and actually use it for the healthcare services rendered to me by other, by different healthcare providers. But life will tell us, as I said, the opportunity to travel is also something that I am thankful for. So I will also finish up with, say, some philosophical conclusions why I believe that the innovations we've seen and about to hear more will sustain. So health systems are and will remain fragmented. I mean, these mobile phones with us will tell that we will get our care in different places, data will be in different places, and it is impossible to hoover that all together. At the same time, this healthcare worker who gives me a second shot needs to know about the previous one. So there needs to be a single version of truth about medical data. And then, if this information is coming from various sources, then there needs to be privacy management, which is linked to the GDPR principles. It has to be purposeful. Only the information and when needed should be processed. It has to be configurable. Only the limited amount of data that is required should be kind of shared or made available to others. And also there is a necessity for transparency and accountability. Either you build AI models, whether and how you create services using telemedicine, it has to be auditable, and this is what some of the technologies can prove, can deliver, and this is what I hope we have also learned from the pandemics. And I will not tell you more about the company, but that I love it and I love what I've been doing, and thank you once again for the opportunity to be here.
Thank you very much. Thank you, Ian. Thank you for sharing. You hear me? No. Thank you very much, Hein, for this presentation. We will take some questions afterwards, so please start to think about your question. I'm very pleased to welcome now Andrea Barbiero, who is co-founder of this wonderful initiative, SalusCoop. It's a citizen-led data cooperative. So Andrea is a consultant specialized in digital health and healthcare in general. She's Argentinian, but living in Barcelona, working a bit in South America and a bit here, advising some governments, advising some companies, while doing a lot of things. Coordinator of WeShare community here in Barcelona, so a very passionate person. So I'm very pleased to have you here. Please explain us what you've been doing this last month and years, actually. Thank you, Andrea.
Can you hear me? No?
Okay.
It's not working? Now, yeah. Thank you very much, Juliana and EHWS for this invitation. Really, we appreciate this moment to have to explain our project that is a citizen-led data cooperative. I would like to start my, let's see if it is working.
If it's not?
No? Yeah,
it is.
I would like to start my intervention with this quote that was said for Angela Merkel in a few years ago in one of the World Economic Forum. No? Data is the raw material of the 21st century, and the question of who owns the data will decide in the end whether democracy, a participatory social model, and economic prosperity can be combined. I can't be more on this information because I think it's one of the new contexts we are living. No? We are living in a new context, a new social context in which the change of the capacity of the citizens and social demands are arising. We are in a new technology context in which the data-driven innovations and technological developments and research are arising as well. And we are living in an economic pressure in which the public health systems need another opportunities to reinvent it. No? We saw the last year with the pandemic that everything is health. No? In our life is health. So we are living in this context in which the data have more value than ever. Our data is ours, no? It's mine, no? We know that. We know that the data is mine because more than we know it, that we have the GDPR law that said that you have your rights to take your data. And the last right, that was the portability of the data, I think was one of the best, no? Because gives us the information, gives us the opportunity to take that data and move around. No? We know that we have to do more with less, and sharing our data and giving our data is sharing our knowledge. So we have this economical pressure, and we need to do more. No? As citizens, we have the capacity to donor our blood, to donor our organs. What about our data? How can we do it? And the COVID-19, I think, raised the awareness about the data sharing and about the privacy about our data. Last year, we were talking all the time about privacy, about contact tracing app, and all this information that we have sharing for this emergency moment. And I think this is a new opportunity to still talking about this and how we can talk about this. No? We as a citizens, years ago, 5 years ago, a group of citizens coming from social science and digital health, we thinking in how can we help citizens to share their data, and how can we help researchers to have more value data, no? Not only for researchers to have more, only for the citizens to manage and to have the opportunity to get involved in this all data sharing movement. No? So that's why we funded a cooperative model. We saw that this was the best model to have the decisions together and to be in the role, active role of the person to say what they have to do with their data. No? These third-party organizations that are like ours is in a good moment right now because we are in the European Data Governance Law, that is a new framework that is working on how these new organizations are going to get involved and going to be more trust and be more transparency for all of us. No? One of the chapters of this framework talk about data altruism. SalusCoop has it's altruism movement, and we want to share the data only for social good and common good. As I told before, we make a research to understand which was the best way to make this this movement. We founded SalusCoop in 2017, and in 2018 we made an intelligent collective experiment, what we call 3M, in which we were looking for the conditions that the persons will willing sharing their data. No? We make a survey in which 600 participants answering more than 8,000 of these scenarios, in which we take some conditions and we pack it in a Salus ACG or Common Good license. These 5 conditions are that we are going to use the data only for health and social, data will only be used for health and social studies, non-commercial research projects will be promoted by entities which support general interest or public institutions, universities, and hospitals. Shared results, every result that using this data has to be open, for everyone to open the knowledge for everyone. No? And I think in this moment of COVID, it's really important that, and we saw that the collaborative movement, we can share a lot of more. No? Maximum privacy, all the data will be pseudo-anonymized prior to use. We are working in the technology to help to do this. And one of the things that the GDPR asks for the citizens, gives to the citizens, is to revoke any moment to access to this data. No? So we are now developing the technology that is going to permit this. We are going to this technology in blockchain, that is this technology that helps us to this decentralized and this sovereignty of the data helps to to fix this, to make this, and we are taking data from our phones. We are not producing new data because we are producing data all the time. That's why we are going to take the information of the Google Feeds or the HealthKit apps that are nowadays in our phones, and then we are going to introduce more type of data in the future. No? All this data is going to be stored in a decentralized storage unit that is system that is IPFS, that is going to be a place in which the people will have the data as itself. No? And all this, we are going to do it end-to-end, encrypted data, without pseudo-anonymization. What are we doing right now? No, we are doing a project with Aaviksoo cooperative, that is a very big cooperative here in Spain, in Catalonia, and we are making a cohort of citizens who provide their data for research for COVID-19. We are working with some research centers that are having some research projects using data citizens for COVID. We have the support of Catalan movement, the Catalan cooperative movement, and Catalan government, and as well as Mobile World Congress Foundation. And we are going to have tools for recruiting these citizens and these tools for the researchers to have more and value data to research about health and social. So I would like to invite you to come as researchers, as citizens, to share the data and be part of this movement. Thank you.
Thank you. Thank you very much, Andrea. So now we have some time for questions from the audience, a bit less than expected, but we still have some time because after that we will have to clean the room. This is the rule. All the room will be cleaned, so we will have a break after this question session. So do we have questions in the room, please, about these COVID innovations you have seen? Yeah, here, please, in the middle. Another one for afterwards.
My question is for Joan. First, congratulations for your work. I think it's very interesting. But my question is, you end up having a system that has data from images from the lungs and also from a blood test. My question is, what does the system add to, accuracy something to blood test for COVID? Is it more accurate? Is it more quicker? Or?
Well, hello? Can you hear me? Hi. Now, thank you for question. Actually, the model what it did is that it's quicker, and actually it has. Okay, it's difficult to say this because it's not in. I don't want to say it in an offensive way, but it's reproducible. So if you show the same image and the same blood test to the model twice, you will have the same result. But sometimes when you change between professionals, this is not always the case, and it's sometimes difficult to get this. But and I'm saying this because I think that this kind of solutions could give like a ground floor where we could build something else in combination with the physicians. So yeah, the algorithm it's actually a little bit more accurate than the radiologist from the hospital, and it's actually quicker. Since after just 10 minutes you have the result, and then it's this reproducibility issue that also adds up in the healthcare system.
Thank you, Joan. Another question in the room? No? I had a question for you, Amit. You were talking about the fact that before the pandemic, only 24% of 1 on 4 healthcare provider had a virtual care program or had planned this thing. So during the pandemic, you explained that they had to buy some solutions to cope with the situation, etc. Do you think they took the opportunity to have a strategic vision for the next years? And how do you see your clients having this vision for the future on passing to virtual or to online, more things that they've done during the pandemic?
So I'm not sure I heard your question because there's a reverberating echo here.
The question was about the vision, the strategic vision of your clients, because they had to change in a few months, but what is the future, the perspective for them, from them?
Yeah, so our customers, hospitals, doctors, clinics, they definitely have embraced the concept of telemedicine. Necessity is drove during COVID. For the first time, you saw, I deal with cardiologists, and you see cardiologists who are used to making a lot of money sitting at home doing nothing because all they could do was take care of emergency issues, not the regular problems that 120 million patients. So they've learned that they have to adapt. It's not a matter of choice. Before they could say, this is not good, this is not the same, which may be true, but the COVID has shown that you've got to provide some other solution than an in-person visit. And so I'm seeing them all adapting both technologies and solutions, things that they could not even imagine to do before in a person's home. They're doing it now. Of course, you cannot do surgery and things like that, although that too comes with remote tools as well. But I think that they've all accepted that as fact. No one is arguing that this is where the future or the presence of the future is there. And the only thing that they are concerned about is payments and remuneration, to make sure that they get paid the same if they do things remotely as they were before. But I think, like I said before, I think being in the digital healthcare right now is a great time because you don't see, those of you who've been around to see the change in telecom, remember how we used to do things versus how we are doing things today. A $1 trillion industry has changed. This is right now, we're in the middle of this kind of transformation, and it's very exciting to me.
Thank you, Amit. I had a question for you, Ayn, as well. A bit similar question, but passing from crisis response to preparedness, so it means to anticipate potential future problems. So you have worked in government, you are now in the industry side. What is your view in your contact with the WHO, with other governments, with other companies? Do you think we will be prepared next time?
Well, I think that many countries have seen the same statistics, that initially the telemedicine consultations, for example, went up dramatically, and then when the last summer as well and also autumn, it was a little bit eased before another wave came, so they kind of went back, and the reasons were explained quite well. So on one hand, the policy makers and the payers and insurances, public or private, they would like to be innovative. They think that they now know that this is possible, but healthcare is complex and entangled, and there are interests that are not always aligned in the same direction. So in order to sustain, and I think this is still an opportunity, that if there are leaders, and sometimes I even think that we need political leaders. So political leadership to kind of sustain the momentum and redefine maybe some of the interests. So, I mean, if everything has happened in the hospitals, so the systems is built in such a way that the money needs to flow through the hospitals. So that there are the great interests not to allow, this money to flow other ways. Yeah. And then you can, bring obstacles where I'm usually working these days is that, the data is difficult to get hand of, there is privacy concerns, we can't solve them. What we have luckily from this pandemic to take with us is to demonstrate, no, you can process data with the privacy properly managed. Yes, you can in certain circumstances convince people that they're willing to give away a little bit of their privacy if there is accountability and transparency because they get a better care. So if we take these lessons and can couple them with courageous politicians and policymakers, I'm hopeful.
Good message. Thank you very much, Hein. Andrea, perhaps a last question for you. So you've talked during your presentation about the consciousness of citizens of this question of privacy, the debate we had last year. What do you think will stay, will remain after the crisis? Do you think that we are at the beginning of a more active participation of the citizens in all of this?
Yeah, I think that the last year was a learning year, no? to understand how the value of our our data have this value to share, and we have made a vaccine in a few months because we were sharing and working together, all the actors, no? And I think the citizens or the patients or the caregivers have to be in an active role in the center of the health system. So that's why I think that this is the moment to rethink our health systems, to rethink the health system, to take off the hospital to primary care or to home care, and all this is taking the system or thinking the system in the place the people are, not in the place we are working on. So I think that this is a new movement where we're thinking this system thinking in the person at first, and the data is with the person. So the person is moving, the data has to move as well.
Perfect. So thank you very much. We are running out of time. Thank you very much to all of you. I invite you to we had a last question, but it should be very quick, very, very quick. A second one. Okay.
Thank you. Very quick question. Thank you. 2 weeks ago, the European Union supported the EIDAS self-sovereign system, no? And how do you think it will influence, after all this COVID pandemic, the support of the EU on the self-sovereign identity project?
Is that
for who?
Yeah, I can be very quick. Coming from a country that has used digital identity, it's not self-sovereign identity fully, but I can, we could have a session and tell that as a citizen I have quite good control over what and why and how my data is being used. I'm all for it. There are certainly, many challenges, many disputes ongoing, but I like it, personally and professionally.
Thank you very much. Andrea, you wanted to react?
There is another question around there.
I'm sorry, we are running out of time. You can continue the conversation afterwards. I want to thank you very much to join us here in Barcelona, physically and presentially. We can applaud the speakers. Thank you very much.